I'm Christine Ingram, I'm a consultant radiologist. I'm not an ographer, I'm an ologist. The ographers take the pictures, they're the technicians. The ologists are the doctors that have been trained in how to interpret the images and what further imaging might be needed. So we know a lot about the pathological processes that can go on, and we're an integral part of all the cancer teams, most of the other clinical teams, to be honest. So I'm going to tell you a bit about how we image GISTs. How did they present? And Robin's talked a little bit about this. I don't see many of the people that present at the front end because they'll present as emergencies or to routine gastrointestinal clinics and so on. But these are the ways they do present, as many of you will be aware. Bleeding's one of them. Something can suddenly go into a blood vessel and bleed catastrophically. A bit of gut can perforate and present as the emergency. It might just be abdominal pain, but lots of other ways too. It might be symptoms of a mass or abdominal distension, if it's a very big tumour, for instance. It might be because you've got organ-related symptoms like stomach problems. And it might be purely by accident. So sometimes you'll come in for a scan for something completely other, and we'll just pick it up by chance. Stomachs are the commonest. Robin's talked about this. I'm going to just go through this bit quite as quickly. So that's about 70%. And abdominal masses can be found for other reasons in other parts of the body as well. I'm just going to show you one or two images now. Can we put these front lights down a little bit? Is anybody able to do that? Because it's better for the pictures.
Switches down there somewhere?
I'll carry on while you're trying to find one. This is a coronal slice of a CT scan. So it's a no, it's not. It's a sagittal slice. It's a slice like that. It's called sagittal because it's the direction you'd pierce somebody with an arrow, front to back. So that's a slice through your kidney here. See if I can do this on the screen. I can.
I think it's that other panel.
It's not showing.
Yeah, that speaker.
No, it's not. Oh, well, that's better. Yeah. Is this showing up on the screen? No, it's not. I'll just point out. This is the stomach, right under the diaphragm. See the air above the diaphragm. And that's a very white tennis ball sitting within the stomach. So that's one of these low-grade GISTs. We used to call them leiomyomas and consider them completely benign, and now they've been quite reclassified. But they're sort of the commonest sort, present with stomach problems, and that's what they look like. Sometimes we'll find some incidentally on a CT colonoscopy or an ordinary colonoscopy. This is a CT technique whereby you get a drug to purge your bowels. They give you a bit of oral contrast to drink, put a bit of air into the bowels by pumping it up.
Sorry, can you speak to the microphone?
Sorry, I forgot. And you can see little polyps, just like we did in the stomach. This one's sticking here. This is a big lump that presented as a mass, and that whole rugby ball in the middle is a cystic GIST on the duodenum, so the bit of bowel immediately after the stomach. Sometimes the GIST was spread into the peritoneal, which is the lining around all the organs, and that can cause other problems. It can cause fluid to accumulate and so on. And they're quite difficult to spot because they can look just the same as the bits of bowel. So this is a lump of bowel with some fluid in it, which is the grey. And this is a rather cystic looking metastasis, which is just enhancing a little bit around the outside, and you need my expertise to tell what that is and to distinguish it from the bowel itself. This is a very big lump in the left side of the tummy. It's got air in it. The black bits are air, but it's tumour. So how does a tumour get air in it? The only way it can get air in it is if it's related to the bowel and it's burst through into the bowel. So that's a big GIST, that's eroded through the wall of a bit of bowel and might have bled, might have got infected, might just have perforated and sat there. So it's connecting to the bowel, and that's big enough to have presented as a big mass. So stomachs are usually the ones that are very low risk, and other sites they can be higher risk, as Robin said. I'm not going to show you the picture that was going to go with that because it's not helpful. We talked a little bit about how GISTs spread. If they've stopped being confined just to the primary tumour, they spread mainly to the liver because they're related to the gut by definition, and a lot of the blood supply from the gut goes straight through the liver because that's part of the digestive process. So you get liver metastases. Now, this is a bit unusual. Carcinomas, that's common or garden cancers like lung cancer and kidney cancer and breast cancer, tend to go to the liver and to the lungs and to the bones and to things like that. Sarcomas, the other sarcomas, because yours is a bit different, they usually go to the lungs. They don't go to the glands so much. They tend to go straight to the lungs. So GIST is almost unique among sarcomas in just going to the liver, and almost only to the liver, apart from the peritoneal spread. This is an example of something that grew and what happens when we follow something up. This is an axial slice, sliced that way, so we're looking onto somebody's pelvis, chopped through the middle. So that's just above the hip bones. That's the bladder, sliced through the top, like a top of an egg. And this is the rectum at the back. And this is a lump, quite a small lump next to the anus there. So that's an anal GIST. This is a year later, and it's now filling most of the pelvis. This is clearly one that didn't like Gleevec. And that's another one which is taken nearly a year later, so it's going quite slowly, but it's clearly progressed. It's now filling the pelvis and it's going out into the abdominal wall as well. So that's the sort of thing that we can get in tumours that don't respond very well to treatment. We see that less and less, because Gleevec's pretty good stuff, actually. Now, my job's a bit like, sometimes it feels like a constant game of Where's Wally? You know, that game where you've got all those people, you've got to find that little thing. He's looking for metastases. That and those spot the difference things, where you've got to spot the difference between two pictures. That's what I'm doing all the time, because I'm looking at your last scan, or the one before, and this scan, and I'm trying to work out if it's bigger or smaller, and if there's any new bits that have grown since then. So we're a bit nerdy, really. And we have to measure them all. Now, we have to use the same technique every time because you can't really compare apples and pears. You can kind of measure apples and pears, but you might be measuring different bits of them and it doesn't quite work. So we tend to do the same thing each time. So if we started with a CT, we'll tend to go on with CTs. If we started with MRs, which we don't very often with GIST, because CT is just about as good as MR for the abdomen. If we did, we'd continue with it. And sometimes we'll do that for liver. Not ultrasound. Ultrasound's not quite so reproducible. So my job's mainly comparing CT scans. Now, we have these special standards that we measure to, which make sure that all the research patients and all the different trials are using the same criteria to measure all the lumps and bumps and to compare them, and the same criteria to decide if it's progressed or properly responded and so on. Now, the first of those was the World Health Organization. The one we use mainly now is called RECIST, which is Response Evaluation in Solid Tumours. And that's on version 1.1. They just tweak the criteria every now and then. And that's the one we use for most cancers. Most clinical trials will use the RECIST criteria. There's a different one for lymphomas because they go to lymph glands and they behave differently. But in about 2007, somebody called Choey worked out that actually things that had been treated with imatinib, especially GISTs, actually seem to respond differently. Oops. They found out that the tumour size reduced after treatment with imatinib, but it didn't reduce enough to classify it as a response with these RECIST criteria, because it needs quite a big reduction. So he came up with this clumsy quote that said, we should desist using RECIST, at least in GIST. Which isn't very quotable, really. I'm sorry, I'm just going to go back a moment. So I think I missed a slide that was quite critical there. That just sums up the RECIST criteria, roughly. There are pages and pages of these describing what to do if it's a bone lesion, or if it's fluid in your chest, or you can't measure it properly, or if it's round an organ. But this is basically what we do. We measure up to 5 organs, up to 5 lesions, lumps. Generally the ones we can measure easiest. We measure the single largest diameter. We add them up together, and then we use the percentage of these for these criteria. So a partial response classifies as a equal or more than a 30% reduction in these sums of single largest diameters. Progressive disease is more than a 20% increase, or new lesions, because obviously if there's new lesions that's progressed. And obviously a complete response is when there's nothing left to measure, and stable disease is when it's not changed. So that's fairly obvious. The Chewy criteria, I'm sorry, going backwards again. Lost my mouse. Sorry, I've lost my mouse here. Oh, it's all right, got it. I'm used to a left-handed mouse. So these are the Chewy criteria, which are a little bit different. Selection is just the same. The number of lesions can be just the same. But instead of that 30% decrease, it's only 10%. Or it can just get less dense, because we know that metastases, especially, well, primaries, but metastases, especially in liver, tend to go cystic with imatinib. It's one of these things these inhibs tend to do, and we're seeing it in several other cancers that are being treated with these similar targeted therapies. So if it gets less dense, in other words, more liquid looking, that counts as a response. And on CT, we measure the density of something using what we call Hounsfield units, which are fairly random measures of density, named after Geoffrey Hounsfield, who invented CT. And we just put a little cursor on the screen that will tell us what the density is.
Godfrey Hounsfield.
It was. Just testing. Did you know him?
I worked for him.
I worked with James Ambrose, who worked with him to do the clinical bits down at, in Wimbledon. Similarly, progressive disease is more than 20% increase. So still an increase, but not quite as much. And it hasn't got less dense. So you can have something that's got bigger but less dense, or you can have something that's got bigger but not less dense, and that's progression. Or again, new nodules. Or sometimes you can get one of these cystic metastases that then gets a new nodule in its wall. This is just an example of what things can do. That's a lump in a liver. You see this low density lump here. That's your heart. That's cross section again. So that's through just above your diaphragm. That's the tip of your diaphragm, top of the eggshell. That's your heart. That's the top of your liver. That's your spine. So patient gets Gleevec, and it's gone cystic. It's gone lower density. It's got bigger though. So by the RECIST criteria, we would have said that's progressive disease. But it clearly isn't. It's a lot better. And lo and behold, it then develops a nodule in the edge. Can you see it? There's a little nodule on one edge of it. So by these new criteria, you've got a new intratumoral nodule. So that's progressive disease now. the more cystic liver metastases. And on this one, it's got increased density. Can you see it started filling in on this side, has stopped being cystic. So that's the cystic component's now disappeared. So that's progressed, even though it actually looks a bit smaller. This is I think this is a perforated tumour. It's got air in it again, but this is a lot of thickening around there. But it's got cystic bits in. It looks a bit bigger, but again, it's developed these cystic areas within it. So overall, it's got a decreased density, so it's responded to cleaver. What about other techniques? Some of you might have heard of PET-CT. Anybody heard of PET-CT? 21% of GIST don't show any PET uptake. These really low-grade ones, like the defective ones you see in the stomach, they're not busy enough, they're not reproducing fast enough to show up on PET, so it's not helpful. It's most useful where the CT scan's equivocal, so we're not sure whether it's disease or not, but obviously only if it takes it up. It's routinely used in certain cancers, such as lung cancer, to stage it, and in lymphomas to see what the residual disease is doing, but we don't use it very much in GIST. Just to go through what PET scan is, it stands for positron emission tomography. It's a nuclear medicine technique, usually fused with a CT image, so the CT image tells you anatomically where you are. It's glucose, giving an injection of glucose which is labelled with some radioactive fluorine. It's fluorodeoxyglucose. It's got a very short half-life, doesn't last very long. And that goes, because it's glucose, it goes to areas in the body that are using a lot of energy, using a lot of the sugar. It's glucose, it's a sugar. Sometimes they call it hot sugar. It's not very specific, so your brain uses a lot of sugar, your liver uses a lot of sugar, your heart uses a lot of sugar, areas of inflammation and arthritis use a lot of sugar, but cancers do as well. So it'll pick a lot of things up, but it'll give us an awful lot of things that aren't actually cancer. So that's one of the drawbacks with PET, but it can be a very useful technique, and we do use it as a general screen of the whole body sometimes to see if things are happening somewhere else that might limit our choices of what we're going to do. They've got another sort of measurement thing for PET, and it's called persist, and it measures them rather by doing the diameters. It measures the amount of uptake. And SUV is the standard term. It's called standardised uptake value, and it's a surrogate for the amount of metabolic activity. So similarly, partial response will be a 30% increase in SUV, and progressive disease is a 30% increase. So similar criteria. So that's basically how we measure things. How often do we scan? It's all a bit empirical, really. If you've got low-risk disease, we don't need to do anything. If you've got very low risk, we don't do anything at all. And if it's high risk, there's no point doing it more often than every 3 or 4 months, because if you do it at shorter intervals, you don't spot the difference. It's like if you see somebody every day, you don't notice them aging, do you? But if you've got somebody who's got inoperable or metastatic disease and you're on treatment, obviously you want to keep monitoring that, make sure it's working. So again, 3 or 4 monthly scans would be appropriate for that. But of course you get another one in between if there's a clinical problem. So we wouldn't just stick to those times. So I hope that's given you a bit of an overview of what the pictures look like. And I thought, yes, GIST, they're a bit special, aren't they? They're just a bit different from all the sarcomas, they're a bit different from all the cancers. I'm not sure whether it's good to be different or not when it's a GIST. So I'm going to revamp that and say, if it's a GIST, don't use resist.